I request Dr. Sania Ahsan, consultant Apollo Hospital, to present her topic on fetal MRI, introduction of imaging techniques, and discussion of interesting cases of Apollo Hospital, Dhaka. Dr. Sania Ahsan graduated from Dhaka Medical College in 1994. She started her career as Honorary Medical Officer in Department of Radiology, Dhaka Medical College Hospital in 1996. She worked as Medical Officer in Bardem Hospital from 1996 to 2003. After that, she completed her MPhil in Radiology and Imaging in 1999 from Dhaka University and FCPS from College of Physicians and Surgeons. In 2003 to 2008, she worked in BSMMU as Assistant Professor and Associate Professor. She has many publications in different international and national journals. She has presented research papers in seminars in home and abroad. Her original research paper is titled Developmental Abnormalities of Intracranial Dural Force. She has taken interest in fetal MRI and stroke imaging. Before joining Apollo Hospital, Dhaka, Dr. Sania Ahsan worked as a clinical fellow of Pediatric Neuroradiology and Neuroradiology in Hospital for Sick Children and Sunnybrook Health Science Center, University of Toronto, Canada from 2010 to 2012. Please welcome Dr. Sania Ahsan.
The chairman of this session, my fellow radiologists from Bangladesh and abroad, a warm welcome to you to Dhaka, to this 9th International Seminar on Radiology, SAARC Seminar, Radiology and Imaging. I am Dr. Sania Ahsan, currently working as consultant neuroradiology, Apollo Hospital, Dhaka, and it's very nice to see so many familiar faces in the audience today. And a special welcome because today, this month is our Victory Month, and today I have no conflict of interest to declare, and my presentation is fetal MRI. So I'm just going to talk about a little bit about the techniques of fetal MRI and go through a few cases that we did in Apollo in the last 2 years. So we all know that ultrasound is the predominant modality for evaluating fetal disorders and pregnancy disorders. But since 1990s, with the advent of fast imaging techniques, fetal MRI has been an important adjunct to ultrasound for problem solving. We all know the limitations of ultrasound. We practice ultrasound. First of all, it is very operator dependent. It offers a very small field of view, difficult in cases of patients who are obese, and also if the amniotic fluid volume is less, or in cases of prone and breech fetuses or with fetuses with head lying low in the position, they are very difficult to evaluate properly and resolve. And also it has limited visualization of intracranial structures as the fetal skull ossification occurs later in the gestation. And some known CNS abnormalities like low-lying cord, neural tube defect, tuberous sclerosis, hydrocephalus are difficult to evaluate as a whole, and fetal lung abnormalities are also quite difficult because ultrasound is not the right modality for it. In case of twin and multiple pregnancies, not in the early pregnancy or mid-trimester, later mid-trimester, it is very difficult to evaluate individual fetuses. And in suspected twin-twin transfusions, and when the fetus has a large mass, because of the small field of view, we cannot get a global view. This is what the MRI does. First of all, it offers a global view of the fetus, and because of multiplanar imaging, we are offered more information. Now there are many disadvantages for sure. MRI is expensive, it's not easily available. Not everybody can read the fetal MRI, and also it can cause claustrophobia, especially in pregnant women when they see the huge tunnel that they have to go. They are afraid, and it is very sensitive to fetal motion. So sometimes you have to scan multiple times, multiple planes, and then go through all of them. Then you might be left with few slices that you can really look into. And long-term safety issues has not yet been established. Now, about the technique, what we are doing is we are using 1.5 Tesla magnet, and this is 1.5 Tesla is used all over. 3 Tesla has not been FDA approved yet. No contrast should be given because gadolinium has known teratogenic effect. Optimum time is about 18 weeks, but unfortunately the ones that I show you are well beyond 18 weeks because it's not well practiced in Bangladesh. There's no easy quick referrals. That's why we are getting patients between 26, 30 weeks and beyond. I usually add a diffusion weighted image to the brain because if I want to look at any especially in case of twin transfusion. We are using fast single shot T2 sequences. 20 slices are obtained at 20 to 20 seconds each. Slice thickness is between 4 to 7 millimeter with 1 millimeter probably intersize placing. And you can add a fast T1 weighted imaging to detect hemorrhage or chest for congenital diaphragmatic hernias. Now, how do you read your MRI? You approach it the way you approach an ultrasound. The biometric measurement is possible. You can basically measure and the BPD, FL, and head circumference, abdominal circumference. But actually, I normally don't do it because I always have an ultrasound done, and it's quicker and easier to do and correlate both. So I normally don't do it. And you can have a process of checklists and diligently go through the checklist. Look at all the images, even if they are bad motion, because sometimes 1 or 2 images will give you few answers. And usually it's best to receive it with an ultrasound that in your own institute or somebody you trust, because then you know what you're looking for and you can target the anomaly. Second, always remember that you are putting a pregnant woman in a magnet, so do not just scan sequence after sequence till infinity. Try to go for the question, clinical question, answer the question, and make it short and quick as possible. Because this is a woman who's probably 30 weeks pregnant, in a tunnel, lying there, noisy environment. So you have to consider your patient's well-being as well. So next is that it is MRI, fetal MRI is a very compressed heart. Think about chaos. Case 4, this is a case with fetal hydrocephalus, and the lady also had another child who was 2 years old and had seizure disorder and mental retardation. I had very interesting discussion about this case with Dr. Susan Blazer, who is a very prominent neuroradiologist and author of many books that we read and many publications. So first, the 2-year-old. So you can see this is supravermian hypoplasia. You have a molar tooth deformity, superior cerebellum is hypoplastic. So of course this was diagnosed with Joubert syndrome. And the child, it was, I think ultrasound, by ultrasound the diagnosis was hydrocephalus, but you can see that the frontal, the brain, I've put up normal brain from that age here, and you can see that the brain is quite flat, not enough sulcation gyration, the ventricles are dilated ex vacuo, it's not enough brain matter. But interestingly, if it resolves well, and you can see at the back that this inferior cerebellum and the superior cerebellum is kind of smaller than inferior cerebellum. So this was the question. I think the clinical question was, does the fetus have hydrocephalus? And the answer is obviously no. This is a congenital brain anomaly, and then this child was aborted because they already have a child who is mentally challenged and has seizure. The fifth case is 22 weeks of pregnancy, ultrasound reported as congenital hydrocephalus with possible obstruction at the level of foramen of Munro. So we all know this is potential treatable. You can carry the pregnancy, and if you have a shunt, if you do a shunt early on, whenever the skull doesn't expand, this is a potential treatable condition. But in reality, when we did the MRI, we saw that actually it's not a hydrocephalus. There's a complete destruction of the brain. So you can see how small and dysplastic the cerebellum is. There's no cortical mantle at all. Multiple septation. They're like probably hemorrhages in the depending part of the ventricle. The head is small. So the clinical decision that aided in the clinical decision. This is not a treatable cause. This is a child with severely devastated brain, probably due to intracranial hemorrhage early in the intrauterine period, and then this pregnancy was terminated. So at the end, ultrasound will always remain the primary modality for fetal and pregnancy evaluation, and MRI will be used as a problem-solving and research tool. Thank you all.
Thank you, Dr. Sania Ahsan, for a nice presentation. Ultrasound scan for anomaly is a frequently asked question in a routine US practice. But MRI is now slowly and steadily gaining access in this field. So now the session is open for questions and answering.
So I would like to request Dr. Samshuddha to conduct this session of question and answers, and the speakers will come very in advance.
Request Professor Brigadier Mohammed Jahangir Alam to answer questions. The audience are requested to put questions to Mohammed Jahangir Alam. His topic was techniques for detection of micro and macroadenoma. Dear audience, you are requested to put questions.
In macroadenoma, commonest supracellular tumor is the macroadenoma. Is it correct? We know the intercellular tumor is the commonest tumor is the intercellular tumor is the commonest tumor is the macroadenoma. But supracellular tumor, macroadenoma, is it commonest tumor? It is my question to you, as you have already written on your paper. It is the second commonest point on your.
Actually, macroadenoma is intracellular and supracellular extension. The tumor, macroadenoma, is cellular and supracellular extension.
So that it should be, it is the commonest intercellular with supracellular extension.
Yes.
Not the supracellular commonest tumor,
Probably it was-
macroadenoma.
Probably it was described as.
Thank you, thank you.
Can I request sir? In microadenoma, pituitary microadenoma, you have shown post-contrast images. There are non-enhancing nodules. Is there any role in delayed images? What will be the contrast characteristic delayed images of microadenoma?
Definitely, there is a. Probably you have seen the card. In early images, as there is no blood-brain barrier in pituitary gland, pituitary gland will take the contrast, but the microadenoma will not take the contrast. But as there is no blood-brain barrier, the shading that the loss of contrast will be earlier in case of normal pituitary gland, and the microadenoma will keep the contrast. And if you take a scan after 1.5 hours, you will get, in those cases, the reverse. That is, the microadenoma will retain the contrast and the pituitary gland, normal pituitary gland, will lose the contrast. Very good question.
Any more question?
Another small question. How we can differentiate the cystic degeneration of the macroadenoma from the most common complication of the macroadenoma is the hemorrhage? When we know the most complication of the macroadenoma is the hemorrhage, intracranial tumor, most common tumor for the hemorrhage. And also there is a cystic degeneration in the macroadenoma. The cystic degeneration in the macroadenoma and hemorrhage in the macroadenoma, how we can differentiate on your modality MRI?
Yes, in MRI, if you can detect the flush, that is the gradient echo, you will see the blooming of the hemorrhage. But in cyst, there will be no blooming. I have shown you that you can specifically diagnose that it is apoplexy by seeing the gradient echo. It will be 100% sure that it is hemorrhage. It is not necrosis.
Of course, in Q100 image, hemorrhage
It will be hyperintense.
hyperintense, and cyst will be low intense.
It is
I
a
have shown
subacute.
both the sequences.
Oh, it is a subacute, hematoma, hyperintense on T1.
Okay. Usually
Not the acute hemorrhage.
Let's have acute.
Mr. Chairman, if you take a T1 with an image, it will be plus minus. If it is acute, it will be hyperintense. If it is not acute, it will be plus minus, intermediate signal. But if you take the flush sequence, you will be 100% sure that it is hemorrhage.
Any more question? If no question, then our next speaker, Dr. Sania Ahsan.
Well, Dr. Sania, thank you very much for your nice presentation. It was nice you worked with us in Berlin some time. And then at that time, we had no MRI in Berlin, but anyway, you used to go to the SMU and had been approached to learn a lot of MRI. Your cases were very interesting. Now, the question is, these are done in 1.5 Tesla MRI, I think. Now, if higher strength magnet, like 1.5 Tesla or 3 Tesla, then there is a question of heat dissemination of due to RF pulse. What is the, if there will be any effect of MR in the fetal growth? And other than your center, other centers are not doing it. It is not, routinely practiced. Your suggestion was to do only in equivocal cases. Now, there is some effect of heat dissemination in higher MRI in fetal tissue.
Yes, you're absolutely right, and that is why only 1.5 Tesla magnet has been FDA approved for investigation of fetus in MRI, not 3 Tesla. In my center, we had 2 3 Tesla MRIs and one where I did fellowship, 3 1.5 Teslas, but we used to do all our fetal MRIs in 1.5 because of the FDA approval. Another thing is, remember that the 3 Tesla MRI is more sensitive to motion than 1.5 Tesla MRI. I think another thing is that we are avoiding to do the fetal MRI before 18th week of gestation. So the early time is the time for organogenesis. So most of the time the MRI is done to answer a clinical question. It's not a routine practice. That is there an anomaly that we see in ultrasound? Will this anomaly be a devastating anomaly if the pregnancy is carried forward? So usually it is just to confirm your anomalies that you see in ultrasound, and most of the cases are terminated. So I just have to just say a few words about this. When we fixed the prices of this MRI, fetal MRI, we tried to keep it minimum because sir and I, we thought that we are going to probably give the patient a bad news, but we don't want to give the patient an expensive bad news. So it is not for all the children, it's for children where there is an obvious anomaly and you want to answer whether this anomaly is compatible to life or whether if this child is born, whether it will be born with a great disability. So that's the reason why we're doing this. So it's not for all the children, all the fetuses.
Any more question?
Time.
If there is no question,
Now the place will be given to two speakers by the chairperson. At first, Professor Sania Ahsan, please take your place.
I want to announce that Dr. Kundu was my reading partner.
I am very happy to present the session.
Can both of you read one into
And now Dr. Sania Ahsan will take the place. Now Professor Sania Ahsan will give the praise to the chairperson. Thank you, sir. Our next session will start very soon, and there is a announcement for the participant that the tea break will be on the ground floor at 10:40 a.m. and this will be the end of this session.
So now I conclude this session.
Compressed heart, think about chaos. Case 4, this is a case with fetal hydrocephalus, and the lady also had another child who was 2 years old and had seizure disorder and mental retardation. I had very interesting discussion about this case with Dr. Susan Blazer, who is a very prominent neuroradiologist and author of many books that we read and many publications. So first, the 2-year-old. So you can see this is superior vermian hypoplasia. You have a molar tooth deformity, superior cerebellum is hypoplastic. So of course this was diagnosed with Joubert syndrome. And the child, it was, I think ultrasound, by ultrasound the diagnosis was hydrocephalus, but you can see that the frontal, the brain, I've put up normal brain from that age here, and you can see that the brain is quite flat, not enough sulcation gyration, the ventricles are dilated ex vacuo, it's not enough brain matter. But interestingly, if it resolves well, and you can see at the back that this inferior cerebellum and the superior cerebellum is kind of smaller than inferior cerebellum. So this was the question, I think the clinical question was, does the fetus have hydrocephalus? And the answer is obviously no. This is a congenital brain anomaly, and then this child was aborted because they already have a child who is mentally challenged and has seizure. The fifth case is 22 weeks of pregnancy, ultrasound reported as congenital hydrocephalus with possible obstruction at the level of foramen of Monro. So we all know this is potential treatable. You can carry the pregnancy, and if you have a shunt, if you do a shunt early on, whenever the skull doesn't expand, this is a potential treatable condition. But in reality, when we did the MRI, we saw that actually it's not a hydrocephalus. There's a complete destruction of the brain. So you can see how small and dysplastic the cerebellum is. There's no cortical mantle at all. Multiple septation. They're like probably hemorrhages in the depending part of the ventricle. The head is small. So the clinical decision that aided in the clinical decision. This is not a treatable cause. This is a child with severely devastated brain, probably due to intracranial hemorrhage early in the intrauterine period, and then this pregnancy was terminated. So at the end, ultrasound will always remain the primary modality for fetal and pregnancy evaluation, and MRI will be used as a problem solving and research tool. Thank you all.
Thank you, Dr. Sania Ahsan, for a nice presentation.